good Thursday evening, everyone. I'm sure you already had your dinner. Okay, thank you so much for tuning in to our webinar today with Pantai Hospital Ampang. Hello, I'm Min Yee, a caring pharmacist and also your host for today. So our topic today will be talking about anterior cruciate ligament ACL injuries. Do you know what will happen if the ACL is injured or torn? And how can we overcome or even avoid this problem? Worry not, because we will find out the answers with our speaker today. And without further ado, I'm very excited and very honored to have Dr. Sabbir Ahmad, a consultant orthopedic from Pantai Hospital Ampang here to share with us his insight on ACL injuries. So if you have any burning questions or concerns that have been lingering in your mind about ACL injuries, don't be shy. Do let us know in the comment box below and we'll get Dr. Sabbir to answer them all. Now, please join me in welcoming Dr. Sabbir. Hi, Dr. Sabbir.
Hi, good evening.
Welcome.
Good evening, Min Yee.
How
Good
are
evening,
you?
everybody. Thank you for having me on your Caring live Facebook talk show.
Okay, thank you, Dr. Sabbir. First of all, again, we would like to thank you for spending your precious Thursday evening with us to share your learning.
Yeah, it's my pleasure.
Dr. Sabbir, okay, so when it comes to ACL injuries, okay, there are so many sources of information that we are all really keen to know about, but we especially, or myself, okay, I'm especially concerned whether a patient will need to really give up his or her desired sports activity forever just because of ACL injury. What do you think about this?
Well, firstly, ACL injuries are nowadays very common, especially because of the everybody's very active, especially in sports, football, basketball, badminton, and majority of the patients are usually they're active people. So the main thing is we want them to get back into performing and doing the activities that they're accustomed to, that they want to do, is get back to their lifestyle. So your question being whether they can get back to their previous activity, yes, they can, with a proper operation done, the correct operation done, and proper and correct rehabilitation done post-surgery. Definitely, they can get back to their original activities.
Thank you, Dr. Sabbir. That is really, really great news to all our audience, our viewers who really, really love sports activities. And I'm sure our audience is also very, very eager to find out more from you regarding our topic today, Dr. Sabbir. So therefore, without any further ado, I will now pass my time to Dr. Sabbir.
Okay, thank you. Okay, so we'll start with the ACL. Okay, so the next slide, which talks about the knee joint. The next slide, please. Okay, so basically the knee joint is one of the largest and most complex joints in the body, and it's an important load-bearing joint. The knee is essentially a hinged joint, which is held together by the MCL, LCL, ACL, and PCL. The knee joint has 4 major stabilizing ligaments, and ACL is one of the more important ones. And it is also one of those that easily gets injured. And on either side of the joint, in between the femur, the bone on the top, and the tibia, which is the bone at the bottom, we have 2 meniscus, okay? So these meniscus are the medial and lateral meniscus, and these they can act as shock absorbers, but apart from just being shock absorbers, they also help to keep the joint stable. And then we've got another bone on the in front of the knee joint. It's called the patella, and this is also known as the kneecap.
Thank you.
Okay, so we'll move to the next slide. So the next slide shows the knee anatomy. Okay, so I'll go through this quickly. Okay, the knee anatomy from the, if you look at the diagram on our left, it's the knee joint from the front. So from the front or anteriorly, we have the patella. This is the kneecap, and the patella is attached to the tibia by the patellar tendon. These are all in the front. Okay, so behind that, if you can see, the one there's a structure which is running obliquely. It's called in the front is ACL. The one at the back is a PCL. The two at the side. So this diagram is of the right knee. Okay, so this is the right knee. The one on this, there's another two structures at the side. One structure is the LCL, lateral collateral ligament, and the one on the inner side is the medial collateral ligament. Okay, so these four main ligaments stabilize the knee joint. If you look at the diagram on the right, this is the knee from the side view. Okay, so here you can see from the side, ACL is running from the front to the back, and it's diagonal. It's X-shaped in comparison to the PCL. Okay, so the ACL makes up one of the X, so it's an oblique ligament. Okay, we can go to the next slide. So the next slide, you can see the patella and the patellar tendon has been removed. So in this one, you can see much more clearly how the ACL looks like from the front of the knee. All right, and behind that, that's the PCL. Okay, so what is an ACL? So as I mentioned earlier on, ACL is one of the four main ligaments of the knee that connects the femur, the bone on the top, to the tibia, which is the bone at the bottom, apart from the MCL, LCL, and PCL. MCL meaning the medial collateral, the lateral collateral, and the posterior collateral ligaments. Okay, the ACL runs diagonally in the middle of the knee, as you saw earlier on, which prevents the tibia from sliding out in front of the femur. So it prevents the tibia from moving in front of the femur, as well as providing rotational stability to the knee. It also prevents the knee from rotating. Okay, ACL is about 25 to 35 millimeter in length, and is about 4 to 10 millimeter wide, depending on the patient's ethnicity, sex, and is also one of the, ACL is actually the most commonest injured ligaments of the knee. Approximately 200,000 ACL reconstructions are performed a year. And sorry, the next slide, please. Next slide. Okay. All right. So approximately 200,000 ACL injuries, reconstructions are performed a year. Half of the ACL injuries occur in combination with damage to the meniscus. So about 50% of all ACL injuries, there will be injuries to the meniscus. Okay, I'll tell you later. An ACL in tears can be either partial or complete. That means it can be partially torn or it can be completely torn. Self-healing in untreated complete ACL tear is absent. What that means is if your ACL, there is a complete tear, it will not be able to heal by itself. And untreated ACL tear, that means if you have an ACL injury or ACL tear, and if you leave it, it will lead to osteoarthritis of the joint. Okay, all right, go to the next slide. So what are the causes of ACL tears? The main mechanism of injury is a flexed knee. That means the knee is bent. There is a lateral rotation. That means the knee is rotated outwards, and there is a valgus force on the knee. What is a valgus force? A force coming from outside and hitting the knee from to the side and causing the injury and the knee to move inwards. So this is the most commonest mechanism of an injury. And this usually happens when someone is running and stops suddenly with it and turns, okay? Stops, the feet planted on the ground and turns outwards, and this can cause an ACL to snap. 70% of the ACL injuries occur through non-contact mechanism. All right, so that means 2/3 of the ACL injuries can occur without contact with another person. All right, so these mechanisms such as pivoting, sharp cuts, turns, jumping, and landing on uneven surface or sidestepping maneuvers. This usually occurs in football, rugby, American football, things like that. ACL injuries have a higher risk with athletes who play basketball, football, volleyball, as I mentioned. Several studies have also shown that female athletes have a higher risk of this injury than males because of the difference in the physical conditioning, muscular strength, and also to a certain degree because of the hormones. Okay, the estrogen. All right, can you put the next slide? Okay, so this is basically a short video of how an ACL tear occurs. This is a diagrammatic view. Can we play the video? Are we able to play this video?
It's important to remember that you don't have to be a professional athlete to tear your ACL, and that most of these injuries occur with the same basic mechanisms. Let's start with non-contact ACL injuries. This is the type that we often see when an athlete is cutting, pivoting, sidestepping, or landing awkwardly from a jump and goes down clutching their knee. In many cases, you will notice that the foot may be firmly planted in the ground with the leg away from the body. The ACL will tear when the player transfers their weight and twists at the hips, causing a significant torque on the knee. We call this a dynamic valgus mechanism of injury. To give us one example of this type of injury, let's take a look at how Stu tore his own ACL in the 2013 Gold Cup. Research has shown that there may be several factors that may make certain athletes more susceptible to non-contact ACL injuries. In fact, these studies have shown that female athletes are at an increased risk. The explanation for this may be related to the complex interaction of hormone levels and body types, as well as subtle differences in neuromuscular control. Other factors that may put you at an increased risk include weakness in certain muscle groups of the leg, as well as the way you train. This has been illustrated through high-tech video analysis of athletes that have suffered these injuries. Check out our video on ACL injury prevention for more information. When it comes to contact injuries, the ACL tear will come as a result of a direct blow to the knee from another player or object. This is usually the type of injury that we cringe when we see on television. Depending on the situation, we may see injuries to other structures of the knee with this type of force. Now, these injuries are obviously more difficult to prevent, and when they occur, it's best to have a physician check you out as soon as possible. In either situation, when the ligament actually tears, the player often describes feeling a popping sensation in the knee, and may have severe pain with difficulty moving or putting weight on the injured leg.
Okay, we'll go to the next slide. So the ligament function. So if you look at this diagram, you can see how the PCL, which is on the left, and how the ACL prevent or stabilizes the knee, prevents the knee from translating or moving. So the main action of these ligaments are actually just to stabilize the knee. If you do not have a stable knee, you are not going to be able to conserve the cartilage, the meniscus, which are the main components which causes pain in the knee. All right. So if you look at the diagram on the left, if there's a PCL tear, the tibia will move, or the tibia or the bone which is below will move backwards. Okay. So when you have a PCL injury, your knee, your tibia will, we call it a posterior sag. The tibia will be pushed backwards. Whereas in an ACL, if you look at the diagram on the right, the tibia will be translated or pushed forwards, okay? And your femur, which is your top bone, will be backwards. So this is the main mechanism of injury for an ACL, okay? So the ACL prevents these motions around the knee joint. Okay, so clinical examination. When I have patients that come to me, I will, before I start examining the knee, touching the knee and moving it about, I will always ask a few questions, okay? So the first question will be pain. When did you get it? When was the pain? Was it due immediately after the injury, or did the pain come after about an hour, or did the pain come after a day or two? And then, was the injury associated with immediate swelling? Was there swelling, or there was no swelling, or did the swelling appear after a day or two? All right. So what is pain and swelling? The pain means immediately when there's a pop, you're going to, if there is an ACL tear, you're definitely going to have pain, right? So first thing will be pain, and you won't be able to walk on that leg, all right? Because it'll give way. So then I'll ask, did it give way? Give way means when you try to walk or when you try to stand, you're just unable to because you feel like there's nothing, the leg has just fallen off, all right? So that's giving way. Most of the time, ACL injuries, which causes a complete tear, you will hear a pop, okay? A pop sound. And the knee will feel like it actually came out of the joint, all right? So these are some of the questions that we will ask for a patient who has had an injury. Okay, the next slide. So then we get on to the clinical examination. I will do, apart from all the other normal tests of the knee joint, whereby I will look for the swelling, check for the swelling, check the range of movement. However, in an acute ACL injury or a new ACL injury, you are not able to get full range of movement because of the swelling and because of the pain. So there's a few tests that I will do to see if the ACL is actually completely torn, or if it's a partial tear, or if it's PCL. Sometimes you can mistake it for a posterior cruciate ligament tear. So one of the tests that I will do is a Lachman's test. A Lachman's test, I keep the knee flexed at about 30 degrees, all right? Then I will try and translate or move the tibia, which is the lower bone, forwards, anteriorly, in relation to the femur. So if it can move forward and it translates to more than half a centimeter to about 1 centimeter, most likely the ACL is completely torn. Okay, then the next test that I will do, before that, we will show a video of the Lachman's test, how it's done.
Nice and relaxed. And we're trying to move the tibia anteriorly relative to the femur. So we grab the tibia and we're pulling anteriorly. And we can feel a nice solid endpoint. Hopefully you can see that too. If you've injured your ACL, then there's no firm endpoint that's very lax and it can be uncomfortable. People with large thighs, that can be quite hard to do to examine the knee. So a useful technique is to use your thigh to support the femur. So we want to explain what we're doing. Martine, do you mind if I put my leg under your leg? So we've got nice control over there. The thigh sitting comfortably on my leg. Patient usually feels more comfortable with the knee flexed a little bit and movement.
Okay, right. So the next test that we do is a pivot shift test. Pivot shift test is actually the gold standard test, which will, if it's positive, it tells us that the ACL is completely torn. Okay, we'll do a quick video of the pivot shift test. Pivot shift test to risk.
So we take the heel, put the leg into internal rotation, apply a valgus stress, and we take the knee from a position of full extension up into flexion. So internal tibial rotation, valgus stress, extension to flexion. And that should reproduce a clunking, disconcerting feeling that is something like what the patient felt when they ruptured their ACL.
Okay, so the pivot shift test, if it's positive, there will be a clunk, which will recreate how the injury actually occurred. And this can be very uncomfortable for a patient. That is why it's very important for the patient to be completely relaxed. And you have to do it, you have to be pretty used to doing it to recreate it without causing any pain. Okay, the next we go on to the next slide. After we've done the clinical examination, we will go on to certain investigations, all right? We can do an X-ray. An X-ray is done just to look at the alignment and to make sure that there is no additional fractures. Okay, sometimes you can get something called as a sag-on fracture with an ACL injury, where there's a fracture at the outer part of the tibia. It's a small sliver. So that gives us when we do that X-ray, it gives us an idea that the ACL is torn. So the next slide, which is more routinely done, are the MRIs. Okay, so we do an MRI just to see, apart from the ACL, if there's any other associated injuries, such as I told you, half of all ACL injuries will have a meniscus injury. Okay, meniscus is a shock absorber in the knee joint. So apart from, if you look at this MRI, the one on the extreme left, on your complete left, that's normal ACL. The one in the middle is the torn ACL. All right. It's pretty difficult to see, you know, if you're a first timer looking at MRIs. MRIs, there's so many different structures, you can get confused, but you can see there's a discontinuity in the ACL from the side. Okay. So if you look at the rightmost, it's already labeled, which is the ACL, which is the PCL, the femur bone on the top, tibia on the bottom, and the kneecap, the patella, which is in front. Okay. Right, next slide. Okay, this is an MRI. This is a bit more clear, if you can see, right? Intact ACL on the left-hand side. On the right, it's a torn ACL, where the ACL is torn and it has dropped to the back. Okay, the ACL is torn and it has fallen to the back. All right, so ACL reconstruction surgery. I perform arthroscopic ACL reconstruction surgery. Majority of my cases are very active sportsmen, usually football players and basketball players. Majority, number one would be football, number two, basketball, number three, badminton and rugby. Okay.
No saja.
Okay, we'll go on to the next slide. Okay, so this is how arthroscopic surgery is done with a camera, and we use a shaving device to clear dead tissue and all that. There's a short video we'll just play for how it looks like inside the knee joint. Could we play that video? So basically, this video, it's showing you the normal ACL, and then the PCL, and how a tear, when there's a tear. It's repeating the same thing again. Maybe we could fast forward this slide, please. Okay, so this is the graft, hamstring graft. Majority of my cases, I will use a hamstring graft. Hamstring is your semitendinosus and your gracilis tendons. So usually I'll use 2 tendons from your hamstring, and I will either double it or triple it to make it thicker and stronger. Okay, and this will actually give you at least about 2,000 to 2,500 newtons of strength. Okay, for the new graft. So this video, you can actually see how it's done arthroscopically. It's just diagrammatic. So 2 tunnels are made. 1 tunnel is made in the tibia, another tunnel is made in the femur, and this hamstring will actually tie up these 2 bones together. Okay, at one end, I'll use a button. At the tibial end, I'll use an interference screw. Okay, so this is the button which will stick onto the femur side to hold the graft, to anchor the graft, and I will pull it down. All right, and then at the bottom, I will fix it using an interference screw. And additionally, if it's a high demand athlete, I will also put a titanium stapler at the bottom. So there is 2 anchors. Okay. All right, we can go to the next slide. Okay, we're talking about graft options. What is a graft? So when you have a torn ACL, that torn ACL cannot be repaired anymore. Okay, so we will need to use a graft. A graft is another option which is going to take the place of the ACL that you've torn. So my number one graft options for me is always the patient's own. All right, so it's called autograft, the patient's own tissue. So you've got, usually I will use the hamstring. We can also use the bone, patellar tendon graft as well. So I'll tell you why my option is the hamstring. So if you look at this diagram, you can see how we harvest the hamstring. Okay, I use the semitendinosus tendon and the gracilis tendon. Okay, so if you look at the diagram on the right, that's how we harvest it. Okay, there's make a small incision, and then we just basically pull it out and then tear that. A lot of people ask whether is that going to affect the hamstring? The hamstring is a very big muscle, so just taking those two is not really going to affect the hamstring. But as I said, after the operation, you have to undergo physiotherapy. Okay. All right, so let's go on to the next slide. The graft options. This is the second graft options, patellar tendon. Patellar tendon is also a very strong graft, but as I said, usually I will double or triple my hamstring graft so the strength is equally strong. The only thing with patellar tendon is it can cause a lot of anterior knee pain, the pain in front of the knee, because you're removing part of the patellar bone, right, as you see in the diagram, and that can cause pain, especially with Asians, because Asians, we tend to kneel a lot, because most of us, when we pray, we are kneeling, so it causes anterior knee pain. All right, so allograft, the next slide is an allograft. Allograft is actually a donor graft. That means it is from someone who has donated it, who has passed on. They've donated their organs and we can get it from them. So when do I use allograft? I will use allograft if it's a re-tear. That means a primary ACL operation was done and the patient has re-torn that. Number two, if it's a multi-ligamentous injury. What's a multi-ligamentous injury? When you have more than one ligament torn. If the ACL, the PCL, the MCL, or the LCL, these are torn, then we have to use an allograft because Yosemite and gracilis are not sufficient. Okay. Compare allograft and autograft. Autograft is always better because there's less chance of infection, faster, what do you call it? It assimilates faster to your bone and it is stronger than an allograft. Okay. Next slide. So this is the hamstring, how the hamstring is harvested exactly this way. A small incision is made and then we just pull the hamstring graft out, and then when we reach the musculotendinous junction, we just cut it over there, and then we get a nice hamstring. So once we have tripled it, we get at least about 12 centimeters, which is long enough to reconstruct the ACL. So this is diagrammatic how it's done. We've seen the video. All right, so we can move to the next. The next one. Next slide. All right, so if you look at this, you can see how this, how the new graft is recreated. So in this diagram, it shows two interference screws. This is a BPTB. This is a patella ligament. Patella tendon reconstruction. So there are two screws, one in the femur, one in the tibia. Okay, so if you look at the diagram on the right, this is actually the ACL graft. Okay, this is the new ACL graft. All right, so this is the new ACL graft in the joint. This is from an arthroscopic view. Okay, so it recreates, and it's now basically once you've got the ACL graft in and then you've done the tensioning and tightening, it will be a stable, back to a stable joint. So the goal is a stable knee. Next slide, please. Oh, sorry. Oh, okay. Okay, the goal So if you look at this diagram earlier on, I don't know if we were in that slide. Okay, sorry, I'll go back to this slide. So if you can look at the diagram on the right, that is a new ACL graft. Okay, that's a new ACL graft. The femur is on the top, the tibia is at the bottom. This is in the joint, an arthroscopic view. You can see that it's a very tight and taut graft. Okay, next slide. So the goal, what's the goal? The goal is to get a stable knee that does not give out and allows full return to the desired activity. Okay, so the main aim is to stabilize the joint, go back to your normal lifestyle, normal activity, but it also prevents osteoarthritis in the long run, and this will reduce or even prevent very early morbidity for the patient. Okay, next slide. So what are the possible risks and complications? You can have anesthetic risks, stiffness, infection, blood clot, pain, and numbness. Anesthesia, usually for ACL, you can have a spinal or just half body anesthesia. All right, it's a spinal anesthesia, whereby you can, a lot of the patients, they want to be awake so that we can see the video as we're doing the operation. So because if you have spinal, you're awake. You can also opt to sleep. And other than that, after about 5 to 6 hours, you will regain back sensation of your legs. The next is stiffness. If post-operatively you do not undergo proper rehabilitation, proper physiotherapy, your knee can become stiff. Okay, and apart from stiffness, you can also get weakness of the muscle. Definitely, you will have weakness of the muscle. That is why exercise immediately post-operation is very important. All my patients post-operatively, 6 to 7 hours after that, I will ask them to start doing a straight leg raising test, okay, SLR, which tells me that the knee is stable, and also it starts firing back your quadriceps muscles. Okay, so about 7 hours post-op, my patients will start doing SLR, which is straightening the knee and lifting it up. Okay, risk of infection is always there. So that's why usually we will give antibiotics before the operation, intravenous antibiotics before the operation starts, and I will give for another 3 doses after the operation. Blood clot, it can occur, deep vein thrombosis, if the patient is not moving. That is why, one of the reasons why after 6, 7 hours or a day after the operation, I get my patients to start moving the leg. Pain, numbness, and swelling is pretty normal, and it will usually subside within 24 hours. Okay, next slide, please. So rehab, expect 6 to 9 months of rehab before returning to running, cutting, and collision sports. What does that mean? It does not mean that you have to do 6 to 9 months of physiotherapy. You may need to do a physiotherapy for the next 2 to 3 months. However, to go back to active contact sports like football, basketball, badminton, and rugby, at least minimum of 9 months, because you need to make sure that you gain back the strength of your quadricep and hamstring muscles. Okay, the rehab protocol varies from different physiotherapy centers to physiotherapy center, but the variations are very minimal. The main thing is to get back the strength, get back the sensation, proprioception, get back the balance, and be able to start. My aim is usually to start jogging by the end of 2 months. Okay. So, okay, before we end, so that we have some time for some question and answer session, ACL surgery, there's no surgery which is ever guaranteed. However, ACL reconstruction is a very, very successful procedure, and over time, the success of ACL surgeries is improving. Okay, so I'd like to thank you, and I guess we're open to any questions that anyone would like to ask.
Okay, thank you, Dr. Sabbir, for the very, very insightful presentation. And we actually have quite a number of questions in our chat box.
Okay.
And yeah, I'll read it out to you so you can answer to our viewers. Okay, so the first question here we have is what ACL involves?
What ACL involves?
Yes.
ACL is the anterior cruciate ligament, as I showed in my earlier slide. So ACL is one of the four major ligaments in the knee joint, which stabilizes the knee joint, which keeps the joint stable, right? So when we talk about ACL injury, we talk about an injury, a tear to the ACL ligament. And why our topic today is ACL, because ACL is the most commonest injury for the knee.
Okay,
So
thank
does
you,
that
Doctor.
answer the question? I'm not.
Yeah.
The question was, what is ACL, right?
Yes, the question was what ACL involves.
ACL involves basically a tear of the ACL. ACL injury involves the tear of the ACL ligament. ACL is a ligament which stabilizes the knee joint. One of the four ligaments which stabilizes the knee joint, which keeps the joint stable.
Okay, thank you, Doctor. I
Okay.
hope that clarifies our viewers regarding the question. Okay, and then we'll move on to the second question. Okay, from another viewer. The question is ACL injuries caused by sports or due to aging? What do you think about this?
Oh no, ACL injury is usually because of it's not a degenerative injury. Okay, it's not a degenerative. So degenerative is age related. Okay, age related, you get osteoarthritis, you can get degenerative meniscal tears and all that. ACL is usually because, as I said, 70% is non-contact. That means it can be because of an injury, okay, or sports, right? So even when you misstep, slide, slip, and you twist your body, as I showed in the videos earlier on, you can still get ACL injuries. Okay, so it is, as we age, yes, the muscles get weaker. Okay, so that can cause you to injure, more prone to injury, but it is not age per se. It is more of an injury and sports.
Okay, thank you, Doctor. All right, moving on. Okay, another question. Okay, so from a viewer, she said that I just did my ACL reconstruction and meniscus repair in March 2022. It's already 2 months. She's still unable to bend or squat down completely. She only managed to bend her knee maybe like 110 to 120 degrees. Is that normal?
Okay. It all depends on the surgery. Okay. Usually by the end of 6 weeks, for my protocol, end of 6 weeks, we should be able to get at least 120 degrees. This is 6 weeks. After that, we can by 3 months, I would expect them to get at least full range of motion or movement. So I think 120 in 2 months, I think it's pretty okay. But apart from flexion, the most important thing actually is to be able to completely extend, okay? To extend the knee fully. That means to be able to keep the knee straight or make the knee straight completely. That is very important, okay? Because sometimes we can flex, but we are unable to extend the knee fully. And when you cannot extend the knee fully, when you walk, you will have a limp, okay? So if your knee cannot be completely straight, you will start limping. So apart from flexion, the most important thing is actually to be able to make sure that your knee is completely straight. And then we work on the flexion, work on the range of movement, work on the strength, and also coordination, balance, and all that in physiotherapy.
Okay, thank you, Doctor. So that means she's doing very well and she's just have to be patient, take some time for recovery.
Yeah.
Yeah. Okay, so next question. Okay, I'm sure a lot of our viewers are very curious about this. How can you prevent an ACL injury?
Okay, how do you prevent ACL injury? sometimes, ACL injury can occur in all these sports, right? Contact sports, basketball, football, badminton, soccer, football, and so when you're playing a contact sport, it's very difficult to avoid an injury because it can be a contact. Someone can come run into you, get an injury. But for majority of us, how do we avoid that? Is to always strengthen our quadriceps muscle and the hamstring muscle. Okay, these are the dynamic stabilizers. So we've got dynamic stabilizers of the joint. Dynamic stabilizers are the muscles around the joint. So to reduce the risk of an ACL injury, strengthen these muscles, the quadricep and the hamstring. One of the major components of the quadriceps is called the VMO, the vastus medialis obliquus. Okay, this is the big muscle in the front of the thigh. So strengthen that. How do we strengthen that? Do squats. In the gym, you can do leg extension, leg curls, even normal walking, brisk walking, uphill walking. All this can strengthen swimming. All this can strengthen the muscles around the joint. And by strengthening the muscles around the joint, the risk of injuries to the ACL and the other ligaments is reduced. And of course, wearing the proper footwear and things like that. When you're doing any sports, avoid slipping, avoid rotational forces around the knee joint.
Okay, thank you, doctor. That's very good insight. I realize that I really need to work on my thigh muscles as well. Okay, so another question from a viewer. Okay, he said that he figured out that he has knee pain caused by his right leg ankle mobility, restricted dorsiflexion when when he does squats. So is this the pain caused by him compensating his weight on his ACL? Yeah.
So now he's getting knee pain, right? He's getting knee pain.
Yes.
He's having knee pain because he has an injury on his ankle before.
Yes.
Right.
Yes.
So this occurs to many people because if you have a pain or an injury to one joint, the load on that particular leg can be imbalanced. It won't be balanced with your other leg. So, and then when you walk, your gait, the way you walk changes, right? In our body, the weight and the axis is all the way down to our lower limbs, our legs. So we've got something called the mechanical axis, the anatomical axis. So that's where the weight goes down to our lower legs. So by right, it has to be a balanced weight, right? 50% here, 50% on the right, 50% on the left. But when the person has injury to the ankle, his gait will change. The way he walks will change. The way he stands will change. So the force is now not balanced anymore. The distribution is not balanced. And when there's an imbalance in the forces, it can affect your knee joint because the forces go down your knee joint. The way he walks will be different. So it's not normal anymore. So when that happens, a lot of the time they can get knee pain in the front or at the side of the knee. Okay, it can be because of the patella, the kneecap, which is rubbing against the femur. Okay, or it can also be wearing out of the meniscus or the medial joint line, the joint line on the inner side. So these two can be caused by imbalance of standing or imbalanced posture or an injury to another part of the ligament. Another part of the joint.
Okay, I see, doctor. So does working on his thigh muscle also help with this as well?
He has to not only thigh muscles. He has to. We have to find out actually why he's getting this. All right. Could it be a patella instability? Maybe the patella is not mobilizing properly. It's not sitting nicely on the trochlea. Maybe his axis is more to the inner side of the knee. So then you may have to change footwear. You may have to change the way he walks. We have to do, weight loading tests to see where the load is more many things. Work on the ankle joint, the muscles around the ankle joint, very important. Okay, because he said he got limited dorsiflexion. So maybe his tendo Achilles or the TA tendon is tight, stiffness. So we have to see actually where the root cause is, which is causing this other associated symptoms and pain.
All right, understood, doctor. So that means he'll need a professional assessment.
Yes.
Okay. Okay. So we shall move on to another question. Okay. So this viewer, he asked, if a person has injured their ACL, for first aid, do they need to use splints to stabilize the knee before moving the patient?
Yes. The first thing is actually to put ice to reduce the swelling. Why do you get bleeding? Why do you get swelling? Is because of bleeding inside the joint. And as there's massive bleeding, it causes severe pain, right? So first thing is always ice. And always remember rice, brass, rice, R-I-C-E, rest, ice, compression of the joint, and elevation, okay? So the question was put a splint. Yes, if you have a splint, if you have a brace, put that. We don't want movement of the joint. So a splint, yes, minimize the movement of the joint, more movement of that joint, more pain, right?
Okay, thank you, doctor. Rice is very important. Everyone, please take note. Okay, all right. Another question from our viewer. Okay, she said that she's diagnosed with first stage osteoarthritis and a small bone spur in November 2018. And then the pharmacist actually recommended her to take Osteoactive 3-in-1 joint formula powder. And she did 40 sessions of chiro starting January 2019, then stopped. And now she's still taking the supplement for some time, okay, taking regularly, but lately she's having some triggers. She has slight pain sometimes when she's doing aerobic 3 times a week beside walking. So she's asking if she needs to go back to physio.
Okay, so basically she's got osteoarthritis grade 1. We will need to see she needs to get an x-ray done. Apart from the grade 1, we need to see the alignment of the knee joint, or if it is in the knee joint, we call it a tri-compartmental OA. We've got 3 different compartments. So we need to see actually the pain is from which joint, whether it's the actual knee joint between the femur and the tibia or between the patella, okay, which is the kneecap, or in Malay we call it the tempurung, all right, from the tempurung and the bottom part of the femur, to see if there's a rubbing, okay, between these 2 bones. So very important, as I said, to strengthen your quadriceps hamstring, stabilize the joint. That's number 1. Number 2, you can take all these supplements, okay, glucosamine, chondroitin, PS-cladine. There's so many, glucosamine and chondroitin, they're pretty old already. They don't really help in regeneration of any cartilage or anything of that sort. It just reduces the pain, and studies have shown that it just reduces the pain to a certain degree. There's many more newer ones which claim that they can regenerate cartilage, but that is studies have shown that it's actually not. We don't really get so much of regeneration. So the most important thing is actually to make sure, stabilize that joint, strengthen the muscles around it, mobilize it, keep mobilizing, okay, move the joint, and periodically, if the pain is worsening, it's better to go and see your physician, your doctor, and let them carry out some tests to see if the pain is coming from elsewhere. Because sometimes the pain is not only from the cartilage, it could be from the meniscus, okay, meniscal tear.
Okay, thank you, doctor. All right, moving on. Okay, another question from our viewer. She said that she loves hiking, okay, but lately both of her knees oftentimes got some crack sound each time, and when she squat down or when she gets up, and
Okay.
she's also having knee pain. So is it because is it because her knee is losing the gel already? I believe it's the cartilage. Yeah.
Yeah. Okay. So this is what we call patellofemoral syndrome. Majority nowadays, everyone goes hiking. Hiking is very, very popular now, right? So I get a lot of patients who have not really done much activities before this, but now they've got groups of hikers and then they go hiking, right? So this is a very good it's a very good exercise. It's a very good activity. The only problem is when you go hiking, you are bending and extending your knee flex. Okay, and this causes the wear and tear, as I said, between your patella and your knee joint, right? So excessive hiking causes this rubbing of the patella kneecap with your bone. How do we minimize this? Of course, as I said, strengthen, go back to the basics, strengthen the joint, all right? Her question was whether she's getting osteoarthritis.
She's asking whether is her knee losing the gel already?
Okay.
Yeah.
One thing is losing the gel is the main thing is actually the cartilage is wearing out. Okay, the cartilage. So the cartilage is the layer that protects the joint. All right. Underneath the cartilage is the bone. So when cartilage, there is no pain fibers. So the cartilage, when there's some damage to the cartilage, a little bit doesn't really cause pain. But when it goes deeper, a grade 2, grade 3, or a grade 4 even, when there's bone contact, bone on bone, that's what causes severe pain. And cartilage erosion, if you do not take care of it, it usually does not regenerate, okay? Because our cartilage is hyaline cartilage. To get back hyaline cartilage, it does not really occur unless you do some procedures such as nanofracture and things like that, which gets our own mesenchymal stem cells to close up the damaged cartilage, and we get back hyaline-like or fiber cartilage, or sometimes fiber cartilage. Okay, so it is not basically the gel; it is basically the rubbing of the cartilage and wearing out of the cartilage. So how to avoid it? Strengthen your knee joint. Please wear proper footwear when you go hiking. Make sure you have a hiking stick, hiking gear, so that part of the distribution of the load is on the stick and not 100% on your legs and knees and ankles, because knee and ankle injuries are very common from hiking injuries. I can't hear you. I think you're on mute. Are you on mute?
Yeah.
Yeah.
Yes.
Yeah.
Thank you, doctor. Sorry. Okay, next question. Yeah. Okay, what are the clear indicators that the ACL injury is serious? Yeah.
Clear indicators. Pain, but the pain usually resolves over time. The most what do you call it? The thing that annoys everybody who's got ACL injuries, or the thing that brings them to doctors, is the fact that the knee is loose. Okay, it is not stable. When they go down staircase, they feel like the knee is going to give way, or they're going to fall. So this, when the knee is not stable, especially going up and down staircase, walking down the road, going up the road, they feel like they've got no strength, the knee gives way. That tells you that most likely one of the ligaments are injured or torn.
I see, understood.
And that is in the short term. In the long term, if you do not do anything about it, you get pain from osteoarthritis because your cartilage wears out, because the joint is moving, right? When the joint moves, because it's not stable, it wears out the cartilage, wears out the meniscus.
So reminder to viewers, don't ignore any signs. Okay, and then another question. Okay, is there a situation whereby genetically my Achilles tendon can be smaller or narrower than others?
Sorry, what was the question again?
Oh, okay. The question is there a situation whereby genetically the person's Achilles tendon can be smaller or narrower than others?
Genetically, yeah, of course, there's so many variations. There can be variations in all of us, even in Caucasians or individual compared to Asians. Majority of their bones are bigger, right? hence the ligaments or the muscles which are supporting the bones and the joints will be bigger. All right. So you can have smaller tendons. No two persons' tendons or ligaments are the same size. Okay, that is genetic. And also, number two is it depends on your activity. All right. If you're a sedentary person, if you just sit down, don't do much walking, don't do activities, your tendons will eventually be smaller. Okay, your muscles will be smaller compared to someone who's an athlete. Definitely, their muscles and their tendons and ligaments will be bigger. But it's a lot got to do with genetics, and every two people are different. How do you make it stronger? Basically, to do load-bearing exercises, physical exercise, more activities, strengthen your muscles, which in turn will strengthen the tendons and the ligaments. And of course, nutrition plays a role as well.
Okay, thank you so much, doctor. I think doctors is stressing very, very much on strengthening those muscles. Okay, so everyone please take note. And I think that's all for our questions from our viewers. And I hope that Dr. Sabbir has really answered all your questions and you've learned a lot from doctor today. Okay, so okay, thank you so much, doctor, again, for the very insightful sharing. I've learned a lot from you today, and I believe our audience here does too as well. And to our lovely participants, okay, don't go away first. Do stay until the end of this webinar, as we will be having an exciting giveaway session. And for now,
thank you for having me.
Thank you
to all
Dr.
the
Sabbir.
viewers. And the take-home message is keep active, be active, and do not seek treatment too late. Okay, take care. Good night.
Thank you, Dr. Sabbir. Good night.
Okay, bye-bye. Good night.
Bye.